I have the privilege of introducing Professor Imogen Mitchell, Dean of Medicine at the ANU Medical School located in Canberra in the Australian Capital Territory. Since March of 2020, she has been seconded to become the Clinical Director of the AHPEC COVID-19 response. She will present on COVID-19 Down Under, the Australian experience.
Great, and thank you very much for the privilege of speaking to your group from Down Under. So as Dr. Kavanagh has explained, I'm originally English, so I have a slightly strange accent and have family in the United Kingdom and indeed of California. But I thought to start with, I might just explain where I am situated and also a little bit about the Australian healthcare system for those of you that are not familiar, and then go a little bit towards the story of COVID in Australia, down to a local jurisdiction, and then a little bit about aged care and where we think we've done things right and where we think we've done things wrong. So just to make you all aware, obviously Australia is not Austria, which sometimes gets a little bit confusing. So we are in the Pacific. And if we look where I actually live is in Canberra, which is in a tiny jurisdiction. It's a bit like Washington, DC. This is a self-made city. There was a fight between Melbourne and Sydney, and so they landed in the middle, and that was the Australian Capital Territory. And Canberra is within that Australian Capital Territory. So that's where I reside. It's a population of 300,000. We're surrounded by mountains and 2 hours from the coast. But this is where the federal government sits. We also have local government as well. To give you some background, the Commonwealth of Australia includes 6 states and some territories. Obviously, I reside in one territory. There is also another territory which is much, much larger, the Northern Territory. And obviously, it was originally inhabited thousands of years ago by the Indigenous Australians, the Aboriginal and Torres Strait Islanders. It was actually, in fact, discovered by the Dutch, claimed by the British, and then inhabited as a British penal colony, such that if you stole a loaf of bread, you'd be shipped off to Australia. In 1901, there was a federation of states, as I say, with a few territories. We currently have an approximation of 25 million, but as you can see, the size of Australia is actually very similar to the United States. So we are very sparsely populated, and that's actually been to our advantage in the COVID pandemic. Equally, you can see that a third of the population live rurally. There is a very small Indigenous population, and still quite a significant proportion of Australians are from European descent, and particularly the English. If we look at the Australian healthcare system, it is in fact universal healthcare, although there is an increasing dominance of the private healthcare sector, which is in fact supported 3/4 by the federal government, so it is significantly subsidised. But if we look at the healthcare system, which as I say is a national universal healthcare system, it's divided into 2. Although the money all comes from federal government, it is then dispersed off to the territories and states. If we look at what is funded by federal government, there is obviously Medicare, and that goes to fund things like drugs. It eventually funds the public hospitals in the jurisdictions, although they don't run them. There is obviously population health schemes, and obviously public health sits under that. Importantly, it should be noted that aged care is in fact looked after by federal health and not local health. And that's become important as we've realised that aged care has been a very big vulnerability in Australia. But if we look at what's actually delivered in terms of healthcare, it is in fact delivered by the states and territories. So all the acute care hospitals are in fact run by the local jurisdictions. And the local jurisdictions also deliver the public health services as well. So although originally funded by the Commonwealth, they are not run by the Commonwealth, I mean federal government. And that again is important to understand in terms of what we've done in terms of having a national response, because essentially we are a federated country, and that, as you know, sometimes creates some challenges. So if we look at primary healthcare, in fact, interestingly enough, primary healthcare is funded by federal government. Again, it's universal access, but it is very much on a fee for service, and the citizens have to pay, although in fact they can get their money back from Medicare. They're also looking at rural health clinics and community health clinics. And there are actually a huge number of doctors in Australia, but it's unfortunate they really do not want to go rurally. And I'm sure there are similar scenarios in the United States. So there's been a big push to try and get doctors to go rurally because of the lack of healthcare delivery in the rural and the regional places. I explained a little bit at the beginning that although there is universal healthcare, there is now an increasing proportion of healthcare delivered by the private sector. And indeed, you can see the number of beds and separations is almost as much in the private sector as it is in the public sector. However, the private sector never seems to land up looking after the complex ill or the seriously ill. That is all done within the public healthcare system. And uncommonly, the private hospitals have emergency departments. So predominantly the emergency care is all done in the public sector, which probably has helped us in terms of our response to the COVID pandemic. So if we look to Australia's response to coronavirus, remembering, of course, that our country is very large with a largely dispersed population, although, of course, we do have major cities such as Sydney, which has probably about 5 million people, and Melbourne in Victoria, which is probably about 4 million people. And then there are smaller cities sitting in Queensland, namely Brisbane or Perth in Western Australia. But it is a relatively small population for a relatively large country. And noting, of course, that we are effectively a very big island, again, very helpful when it comes to containing COVID. I'm just going to run and remind us of the timeline. It seems such a long time ago in some respects when this all started, but we're now almost talking a year or so. So let's just remind ourselves what actually happened. So on the 1st of January this year, the WHO was highly suspicious that there was a new virus that was being established in Wuhan in Hubei province in China. It was then, in fact, genetically sequenced, and that was, in fact, released, which has been important in terms of getting vaccinations up and ready so quickly, given that we had the sequence, but many governments have now put money in to generate these vaccines, which is probably why it's happened all so quickly. And then, of course, it started to spread, whether it be Singapore, there was concern in Hong Kong, and then sort of first week of January, there was a case in Korea. Now, at this point, people are not thinking that this is human-to-human transmission, so it's becoming a little unclear as to how dangerous this bug might be. But there's now deaths happening in Wuhan. And the WHO is sort of reassuring us that it's not passing from person to person, and certainly I was not as concerned. But on the 20th of January, there is this first case in the United States, although, of course, we realise now that, in fact, that really probably wasn't the first case. And there is now starting to noises that this might become a pandemic. And there are now cases in Australia by the end of January. There were now travel restrictions, and this is an important landmark for Australia. There were travel restrictions on foreign nationals arriving from China. And so that, I guess, is one of the lessons that we learned, that early on we put a block on people coming in with a high risk of having been exposed to COVID. By the end of February, the Prime Minister declares that we've got an outbreak and that it would soon become a pandemic. This is obviously Australia. And he activates the emergency response plan. And that obviously gives federal government, some powers that they don't usually have. There were then subsequently restrictions of people coming from Korea. And finally, there is a global pandemic declared by the WHO. Now, again, important, in the middle of March, these travellers are now required to isolate 14 days. Cruise ships are now banned. And again, we see that we are now being recommended as citizens of Australia not to travel overseas. And there were obviously many of us who had destinations booked. Again, importantly for Australia, we're suddenly realising that cruise ships are a great melting pot for the dissemination and contamination of COVID. And unfortunately, there was probably some sort of, decision-making which may have been better and stronger when there were a number of passengers disembarked that were not immediately isolated from a cruise ship. So that was, again, a lesson for us. By the end of March, territories and borders were now starting to close their borders. And what that would mean is that if you wanted to cross the border, you had to cross it for a reason. It was either for someone who was imminently dying, or that you had to get healthcare, or potentially some other reasons. And if you didn't have an exemption to pass the border, then you wouldn't be allowed to travel. And even if you did pass the border, you would have to go into 14 days of quarantine. Now, these borders have never been raised unless there is a pandemic. So I believe in 1918, when there was the Spanish flu, for the first time ever, the Victoria-New South Wales border was closed. You can imagine if you're a border citizen, it becomes incredibly difficult to actually run your life because your life is actually split between the two states. So that is involved in a huge amount of process, because once you put an exemption in and quarantine, it really does mean that there's a lot of people that need to be involved in these processes. And then as the borders started to close within the country, increasingly we were now being restricted, and that bars were closed, places of worship were closed. So anywhere that was internal and had lots of people were essentially closed. And obviously this had a huge impact on the economy. And schools were starting to close as well. And by the 28th of March, so we're now, 3 months into this, it was mandated that anyone coming into Australia had to undergo the 14-day quarantine, and that these were in designated facilities, and that there were support structures into these quarantine places such that people who were working there were trained in terms of infection prevention control, and also were appropriately screened for COVID. Now, this interestingly was all on the back of a pretty bad summer for us, particularly in the Australian Capital Territory. If you notice that Canberra, as I say, is 2 hours from the coast, and the coast was essentially under fire. And it was essentially a very unpleasant summer. It was very hot and very, very smoky. So a little like the fires in California have been. And indeed, Canberra probably had the dirtiest air in the whole of the world, which was quite something. So the COVID experience was, as I say, a rather poor ending to what had been already a very bad summer. And the summer, unfortunately, in Canberra also ended with a torrential, massive hailstorm, which I think damaged something like 34,000 cars and numerous roofs. And certainly my own university was severely impacted, which, as I say, did not really help us into managing COVID. And of course, as COVID was striking, I think there was certainly amongst my intensive care colleagues quite a lot of fear, because what we were seeing in Lombardy, London, and New York was the overwhelming of the healthcare system. But what really was striking was, in fact, intensive care was not fixing everyone, such that the risk of going into intensive care was quite significant. And certainly in the United Kingdom at that point in time, it was a 50% mortality. So healthcare was, in fact, not necessarily the whole answer. And we were all scared because, of course, we worked out that 20% of people with COVID were needing hospitalization, of which 5% were also then needing intensive care. So this really felt like this was going to overwhelm our healthcare system. And in Australia, I'm not so convinced at that point in March we were necessarily prepared for this pandemic. And so for my own situation, I got seconded from being Dean of Medicine to be the clinical director of the jurisdictional response to COVID. And so I became almost addicted to the daily data of COVID and just seeing the escalation in cases, and terrified that we were about to undergo the so-called whoosh, which was being experienced in Lombardy and London. But what was fortunate was that our governance in the country, although federated, we formed a national cabinet in March. And this was advised by the Australian Health Principal Protection Committee, the so-called AHPEC. The chair of that Australian Health Principal Protection Committee was the Chief Medical Officer, that's the Federal Chief Medical Officer. And members of that committee were all the jurisdictional Chief Health Officers. So every jurisdiction has a Chief Health Officer, who usually is a public health physician, and had to second in 3 chief medical officers into federal government to help manage the pandemic. The other thing that was important, not only did we have the formation of national cabinet, which was really described as the war cabinet, that there was also an assignment of COVID funding for the jurisdictions, such that if they were spending huge amounts on healthcare, that would be split between the jurisdiction and federal government. So the jurisdictions obviously were operationalising the plans, particularly public health units, but they were very much guided by whatever National Cabinet said and the AHPEC. And this was, in fact, as I say, guiding them. And the acute care facilities were putting plans in place to help prepare for the surge in patients. So if you just look at my own jurisdictional plan, the Australian Capital Territory, bearing in mind that we're only 300,000, although we did say that we would look after our southern New South Wales colleagues, which we need another 200,000. And so that was interesting, crossing borders and jurisdictions. That our jurisdiction plans obviously were public health strategies, We had guiding principles to protect the community, protect our staff, and protect our patients. We had capacity plans being developed, and indeed we also, in the local jurisdiction here, built new infrastructure to try and manage the surge of patients. We also were looking at logistics, and in particular PPE, which of course was increasingly hard to get. Not only was it hard to get, but it was incredibly expensive. We knew that we'd have to look at workforce and change the model of care, and that clearly we needed our finances to be appropriately supporting our response. And an important part of our planning was, in fact, communication to our staff and community. And very early on, we realized that aged care was very vulnerable and would need support. So if we just look at my own jurisdiction, you can see there's sort of what we described as a big tent in what was a soccer oval. And this was a new emergency department designed along WHO guidelines for the management of airborne and droplet diseases. And this could actually house up to 56 patients in the emergency environment. There were 6 resusc rooms. And so this was built in 37 days so that we knew that if we had a surge in presentations to the hospital, that we could actually manage this in a safe way for our community and our patients. So that was very good to feel that our government, the local government, was highly supportive of our suggestions that we needed to make sure that we could manage this. So with all the public health strategies put in place across Australia, what was very reassuring as a clinician that, in fact, in the end, these strategies actually work. So that you can see that we peaked at just over 450 cases of COVID per day. And of course, we would see that as a lot, but obviously when we see other jurisdictions around the world, this is a tiny number compared to what has happened. But for myself, it was incredible to see the response to public health strategies and, in fact, really demonstrate that it works. Until, of course, the situation happened in Victoria. Victoria is just south of the border from New South Wales. And as I say, its major city is Melbourne. Melbourne's probably about 4 million people. But there's also a large rural component of the state of Victoria. What happened in Victoria, of course, is that the hotel quarantine, unfortunately, probably didn't have strong enough processes in terms of infection prevention control. And it also probably didn't have a strong enough public healthcare system whereby that was very centralized, probably under-resourced. And so there then started to be a failure of contact tracing and testing. And so what happened in Victoria over the next 2 months was for us, a very big surge in the number of cases. So that, in fact, although the original Victorian-New South border had not been closed like other people had closed their borders, this then got closed at the beginning of July, just as school holidays started to begin. And by the early August, when there was a peak of 720 cases in Victoria, there was a state of disaster called and declared in Victoria, whereby they went into stage 4 lockdown, which was not relieved until the 8th of November. And you can see at the top in the middle the graph of the number of cases. So having been quite successful initially, there then was a second, if you like, surge of cases. And this had all stemmed from hotel quarantine, where international travellers had come in with COVID and unfortunately had then subsequently spread. And so you can see that the streets and the trains, which are normally packed with shoppers and commuters, there were no commuters and there were no shoppers, and less obviously for food. And over 12 weeks, the Premier, Daniel Andrews, would present daily at press conferences, alerting us to what were the next steps. And his North Face jacket became quite famous or infamous. And eventually, of course, their hard work really did pay off. And you can see in the middle at the top there that the graph of cases came down, and by the beginning of November, there'd been almost no community transmission and no community transmission for, I think, over a month now. And this is now with reinstating hotel quarantine back into Victoria, which they had stopped when this outbreak occurred. So they now hopefully have got effective public health strategies in place and strong enough hotel quarantine process such that it doesn't leak out. Although, of course, we've just now heard in Sydney that there is now a transmission. So it only takes one, and so that can become unfortunate. And indeed, it became unfortunate in aged care. If you look at aged care in Australia, it's a combination of profit, not-for-profit, government-supported facilities. There are over 2,500 residential aged care facilities with 200,000 Australians. And it is regulated now by a federal commission, so that there are standards that they all, whatever background they come from, are under the control, if you like, of the regulator. But there were issues, there have been multiple nursing homes or aged care facilities to issues, and there have been reviews into them. And again, they mostly come down to the leadership, governance, infection prevention, control, and that there have been severe staffing shortages and lack of communication with families, which have all hopefully subsequently been addressed. When Victoria developed some major issues in aged care, there was in fact a federal inquiry, and some recommendations particularly came out, particularly for strength in infection prevention control. But I guess as I sit in Canberra, where we haven't had a community transmission for months now, we just watch in horror as to what's been happening across the world. As I said to you, I have family both in the United Kingdom and in California, and it is deeply disturbing to see what has happened. And I guess when I saw that public health measures had worked in Australia, I did speak to the local chief health officer and said, every death from now on in will be a failure of government. And I actually probably still believe that, because if you are strong enough and can put these processes in place, however unpalatable, they actually do work. So I think it comes down to strong leadership. I was very aware when I got over the first wave that there was no premier or prime minister that was going to tolerate further death from COVID, believing that public health strategies worked. I think it was very reassuring, not initially, but very early on, within 2 weeks, that the Prime Minister was listening to the science. There have been some very strong public health teams, particularly in New South Wales. I mean, Sydney is a population of 5 million. They do have residencies which are very close together. It is decentralised, so there are just as strong public health units in my own local New South Wales region. It is effective and it's adequately staffed. I think that's where Victoria fell down, but is now strengthened. And as I say, closing the international border, making people quarantine, reducing indoor gatherings, that COVID is part of our lives. Every day when I go to work, I have to sign on to a digital health screen. And every restaurant I go to, I have to screen in on an app for contact tracing. I think there is a sense of fear, so that we actually don't want to see what's happening elsewhere in our part of the world. And I think, as I say, there is data to support the fast and hard lockdown does in fact probably, and this will be interesting subsequently, does better for the economy. And so throughout the COVID, I have a hill that I can run up, well, to run slowly. And sometimes it's been very hard to imagine of the destruction and devastation that is going on around the world, because it's such a beautiful place, and we wouldn't know that COVID was going on, but I know, and obviously speaking to family and friends, that it very much is. And I also have the luxury of being able to run along beaches for holidays where it's much less likely to have COVID. So on that positive note in Australia, I will have some time for questions if allowed. So thank you, Dr. Kavanagh.
Dr. Mitchell, I would like to ask the first question. Has the strategy of the public wearing masks been implemented in Australia?
Yeah, no, so it's been interesting, the mask situation. So I can tell you that in the Australian Capital Territory, we've never been asked to wear masks. But then our caseload has been absolutely minuscule. I think in total over the last 10 months, we've had 114 cases. Having said that, in Melbourne, they mandated the wearing of masks at the beginning of August. They've now relaxed that to the point that when you're on public transport or feel you can't physically distance, that you should wear masks, particularly indoors. In Sydney, again, the similar situation. They never mandated masks. They highly recommended it when there were more cases in Sydney. I think now you would find that in Sydney, people would be wearing them on public transport or where they can't physically distance. So I think if there was the caseload, I think there would be a very strong push from public health and federal government that we should wear masks. I think it's just because our caseload has been so low that it hasn't been recommended.